So it's an absolute pleasure today to have one of our externally invited speakers. We have Dr. Ahmad Makin, who is a home dialysis fellow at the University of Toronto. I want to say thank you. You're the first external speaker of the year, and we really appreciate that this is becoming more of a group activity, and you were willing to volunteer to go first, so we very much appreciate that. And he's going to be talking to us about sex differences in PD discontinuation. Take it away.
Thank you so much. It's really a pleasure being here today with you at the ISPD North American Chapter Journal Club. And I'm really delighted to be part of this to promote home dialysis globally. So the article that we will be discussed today focuses on the association of sex with all-cause and cause-specific peritoneal dialysis discontinuation. So it's a retrospective cohort study that included incident dialysis patient who started and initiated on peritoneal dialysis as their first dialysis modality. So this study published in the AJKD last July 2025, and the data were obtained from the Australian and New Zealand Dialysis and Transplantation Registry, and it included Australian patients. And here is my presentation outline, but before we dive into the article's details, so let's first review the previous literature on how sex influences the CKD prevalence, progression, and the dialysis modality. So now, when comparing between males and females, certain biological and kind of sociocultural behaviors might contribute to the difference in disease progression, prevalence, and treatment options. So recognizing such differences might help in revealing certain new disease mechanisms and probably even new potential therapeutic options. And when assessing the so when assessing the prevalence of stage 3 to 5 CKD globally, and with the difference in data, in the methods of data obtaining and collections, and with the difference in the eGFR estimation equations, and with the exception of Japan and Singapore, most countries overall report high prevalence of CKD in females compared with males. And to be honest, the sex difference varies across different countries, which is most pronounced in countries like France, Thailand, Portugal, and Turkey, where the prevalence is almost twice as high in females compared with males. Now, does this trend of higher CKD prevalence extend into the risk of progression and the requirement of renal replacement therapy between both males and females? And in fact, most of the population-based studies indicate that males probably have faster decline in kidney function compared with females. And for example, this study from the European Renal Association Registry showed that the overall lifetime risk of renal replacement therapy is lower in women compared with men. And this difference was persistent and consistent across all age group and among all European countries that included in the registry. I mean, the overall lifetime risk was around twice in men compared with women. And another large cohort from Alberta, Canada, where they included around 3 million individuals. And it showed that the lifetime risk of end-stage renal disease, again, was consistently higher for men compared with women. And this was among all age groups and among different glomerular filtration rate levels. Now, if we focus on even if we look into the US data, the epidemiological patterns are almost the same. So despite the prevalence of CKD is higher among females, more men initiate dialysis and underwent kidney transplant compared with females. And again, this imbalance might represent both certain kind of biological factors like faster decrease in the kidney function or variation in sensitization, for example, but it might also include sociocultural differences like disparities in healthcare access or different in the attitude toward illness and therapy. Now, if we focus on BD discontinuation, one should be aware that the BD discontinuation is not uncommon. And in fact, less than 20% of Australian patients remained on BD after 5 years of dialysis initiation. And among the causes of the BD discontinuation, death accounts for around one quarter of the cases. That's followed by infection, then inadequate dialysis. And we have many previous studies assessed before the role of sex and the dialysis-related outcomes. For example, Dr. Lim and et al. Published a study in the AJKD in 2022 where they included around 53,000 incident dialysis patients, and they included both hemodialysis and peritoneal dialysis patients. And they assessed the survival disparities between males and females. And what they found that compared with males, females get a higher risk of all-cause mortality within the first 5 years of dialysis initiation. And despite the fact that the cardiovascular disease death were lower in females compared with males, this survival difference was driven mainly through infections and dialysis withdrawal. Now, if we focus on BD discontinuation and the role of sex, the earlier studies showed no statistically significant difference between males and females. However, most of the recent studies showed that give us a trend that males probably get a higher risk of BD discontinuation compared with females. So, for example, a study from New Zealand showed a 14% lower risk of BD discontinuation in females compared with males. And we get another studies from Taiwan and US, which showed the same finding that probably males have higher risk of technique failures compared with females, which might increase the risk of BD discontinuation. Now, a major issue is the inconsistent definitions and reported outcome between different registry and studies. So this might affect the comparability and reliability of the reported outcomes between different studies and registers. And if we look into the BDOBS data, where females accounts for around 43% of the population or the cohort, females were slightly older, have low residual urine volume, they have a lower rate of diabetes, and they were less likely to use APD. And when they compare the clinical outcomes between males and females in the BDOPS, actually females had a lower risk of mortality, had a lower risk of transfer to hemodialysis, had a lower risk of peritonitis and lower peritonitis episode, and they got a lower access to the transplant waiting list. So now let's go back to our articles today. Again, it focuses on the association of sex with all-cause and cause-specific PD discontinuation. And what makes this article different than the previous literature that they were trying to focus on to determine whether the effect of sex on peritoneal dialysis outcomes is whether it's like direct or the effect is through certain mediators that setting along the causal pathway that might probably explain the association between sex and the BD outcomes. And so they included adult patient with incident kidney failure who began and choose BD as their first dialysis modality in Australia. It was a retrospective cohort study. Data were obtained from the Australian and New Zealand Dialysis and Transplantation Registry between 2005 and 2019. And they excluded those with no residential postcodes at dialysis initiation, along with those with a prior history of hemodialysis for any duration, and those with a previous history of kidney transplant. And they started follow up those patients from dialysis initiation till kidney transplant, recovery of renal function, death during dialysis, or till December 31st, 2019, whichever came first. And sex was their main exposure factor as recorded in the registry. And the registry classified male and female as either like the sex assigned at birth or as the gender identity. Because prior to 2018, the Australian and New Zealand registry did not differentiate between the biological sex and gender identity. And they collect the baseline characteristic at BD initiation, which includes certain demographics like age, sex, certain comorbidities that include cardiovascular disease, diabetes, chronic lung disease. They get an information about the peritonitis episode, the geographic remoteness, and primary cause of kidney failure. Then their primary outcomes were all-cause BD discontinuation, which was defined as transfer to hemodialysis for 30 days or more, and death on BD or within 30 days of transfer to hemo. Then infection-related BD discontinuation, which was defined as peritonitis, tunnel or exit site infection, abdominal abscess, or diverticulitis, and inadequate dialysis-related BD discontinuation, which was defined as inadequate solute clearance, issues with the UF, like excessive or poor ultrafiltration, and poor nutrition. In their secondary outcome, the secondary outcome were all-cause transfer to hemodialysis, which was defined as the transfer to hemodialysis for 30 days or more. Now, they identified certain potential mediators, and this is a nice acyclic graph which shows the relationship between and the direct and indirect effect of sex to the all-cause and cause-specific BD discontinuation. And they identified certain potential mediators that might explain the effect of sex on outcomes based on prior evidence. Those mediators, the socioeconomic status, and they determine this based on the residential postcode at the dialysis initiation. Then the geographic remoteness, certain comorbidities like cardiovascular disease and diabetes, BMI, smoking status, late referral, and history of previous peritonitis. At the same time, they identified certain confounders which might affect both the exposure and the outcomes, which include age, ethnicity, residential state, and the dialysis era. And I believe the statistical analysis were a main part of their article, and I believe it can be divided into 4 main categories. First is the descriptive statistics, where they used median, mean, and proportion to summarize the baseline characteristic. They use chi-square analysis of variance and Mann-Whitney U for comparisons between male and females. And for the missing value imputation, they use the chained random forest for certain demographics and socioeconomic and certain comorbidities. Then for their main analysis, they use the cause-specific hazard models to address the question of association between sex and BD discontinuation. And I believe they handled the competing events carefully, and that was treated as censored events. So for all-cause BD discontinuation, kidney transplant was the competing event. And for the cause-specific BD discontinuation, death, transplant, or other BD discontinuation reason were the competing events. And I should mention this before, death was treated as a discontinuation event in all cause BD discontinuation, but as a competing events with the other outcomes. So the estimate of the cause-specific hazard models were expressed as cause-specific hazard ratio and a 95% confidence interval, which tell us the instantaneous risk of an event comparing males and female with the considerations of the competing events. They used a mediation analysis, which is a counterfactual framework. The aim of the mediation analysis in this article were to identify the potential mediators that we mentioned before, and to assess whether this can cause indirect effect on BD discontinuation. So the aim was to decompose the total effect into a direct effect by sex itself or through indirect effect through those mediators. And they use some kind of bootstrap methods with an average results of around 125 repetition for variance estimation. And the effect expressed as a log hazard, and they calculate the relative risk, which is the direct or indirect effect divided by the total effects, and they adjusted for certain confounders. Now, last part of their analysis was the sensitivity analysis. The main idea of the sensitivity analysis, the aim was to validate the cause-specific model results and to check the robustness of the primary results. Now, if we move to the results, they included around 9,748 patients, incident patients who started BD as their first modality in Australia. Among them, around 39% of their cohort were female and 60% were male. And this is almost consistent with the previous literature, where females initiate dialysis less compared with males. And the median follow-up was around 1.47 years. Out of the 9,700, around 6,000 patients experienced all-cause BD discontinuation. 3,600 were males and around 2,300 were females. And among those 6,000, 2,980 died. And as shown in the figure, 3,900 transferred to hemo. From those who transferred to hemo, the majority were due to infection-related causes, and around 800 due to inadequate dialysis-related causes. So 1,900 of their cohort underwent a transplant during the follow-up, and 1,841 remained on BD until the end of the follow-up. And I brought this from their supplementary file, which showed the causes of death while on BD and within 30 days of transfer to hemo. And you can see that cardiovascular diseases were the major cause of death in males and females. That's followed by withdrawal of dialysis. And you can see here a bit of higher proportion of infection among females compared with males. And among the causes of BD discontinuation, death was the major reason of BD discontinuation among their cohort. That followed by other reasons, but also, if you can see here in the infection-related BD discontinuation, again, females had somehow higher rate of infection compared with males. And as I said before, around 1,900 patients underwent a transplant as part of their causes of censoring during follow-up. Now, this is table 1, which shows the baseline characteristics stratified by sex. And you can see that male were slightly older with a median age of 63 compared with female with a median age of 60. Males had a higher proportion of cardiovascular diseases and diabetes when compared with females. But females were having a higher proportion to be in a lower socioeconomic status. They live remotely more, and there was a trend that they are more obese, predominantly non-smoker. And when we compare between males and female in terms of late referral, there was no statistically significant difference. And I'm not sure if you can see the peritonitis episode. There was no statistically difference between males and females, though there was a slightly higher rate of peritonitis in females compared with males. Now, moving to the outcomes. So their primary outcome was the association between sex and all-cause and cause-specific BD discontinuation. And males were more likely to experience all-cause BD discontinuation compared with females with a cause-specific hazard ratio of 1.09, which is consistent also in the competing risk analysis, in the sensitivity analysis with 1.07. Males were also more likely to experience inadequate dialysis-related BD discontinuation with the cause-specific hazard ratio of around 1.71, which is again consistent in the sensitivity analysis. However, there was no statistically significant difference between males and females in terms of infection-related BD discontinuation. However, males tend to less likely experience infection-related BD discontinuation in the fine and gray in the sensitivity analysis model, but not in the adjusted multivariable analysis. And If we move to the mediation analysis, where they assess the direct and indirect effect of sex on BD outcomes, BD discontinuation outcomes. So this table shows the total direct, indirect, relative effects of sex on all-cause BD discontinuation. And overall, males have a higher risk of all-cause BD discontinuation, around 7% higher hazard rate and instantaneous risk compared with females. But if you can see here, most of this effect is indirect, like 77% of the effect is indirect of the total effect, which is predominantly due to cardiovascular disease, which almost accounted for around 50% of the total effect, followed by the smoking status and diabetes. And the direct effect of sex is almost statistically non-significant. Then you can see BMI here acted as a negative indirect effect because the higher hazard rate was associated with the higher BMI, and as I showed you in the cohort before, females were more likely to be obese compared to males, which might attenuate the total effects on this mediation analysis. In terms of transfer to hemodialysis, again, males have about 10% higher hazard rate of transfer to hemodialysis compared to females. And this time, most of this effect is actually direct and related to sex itself. It's around like 75% of the total effect. However, still we got cardiovascular disease and diabetes as a potential mediators that might explain the transfer to hemodialysis, though the overall indirect effect is less than 25%. However, in contrast, in inadequate dialysis-related BD discontinuation, again, males have a higher risk and hazard rate of around twice as high as females. But here, most of the effect is through, it's like a direct effect through sex itself. It's around 94% of the total effect. And none of the mediators showed like any indirect effect for the inadequate dialysis-related BD discontinuation. I brought this from their supplementary file again, and in terms of infection-related BD discontinuation, there was no difference between males and females in terms of total effect, direct effect, or like no significant mediators. So to summarize this, males were more likely than females to experience all-cause and inadequate dialysis-related BD discontinuation, as well as transfer to hemodialysis, but not infection-related discontinuation. And around 75% of the total effect of sex on all-cause BD discontinuation was mediated by factors, mainly cardiovascular disease, smoking, and diabetes. Then cardiovascular disease and diabetes again mediated some of the effect between sex and transfer to hemo, but this explained less than 20%, 25% of the total effect. In contrast, the effect of sex on inadequate dialysis-related BD discontinuation was mainly direct, with minimal influence from indirect mediators. Now, one can ask, why do males have a higher risk of transfer to hemodialysis and inadequate dialysis-related BD discontinuations compared with females? And to be honest, the reasons are not well understood, but one of the potential explanations that may be more reliant on caregivers for BD assistance, which might prone them more to caregivers burnout and BD discontinuation. Another hypothesis that it could be a potential for measurement errors in dialysis adequacy between males and females. And we know we can determine this through the weekly urea KT overview. And we know that females generally have a higher proportion of body fat and lower total body water volume compared to males, which might lead to smaller calculated volume of distribution, hence like a higher KT over V. And we know from before from the Bosca and Ital, where they assess the dialysis adequacy in PD patients, and they actually compare between the dialysis adequacy indices and the body composition parameters, and they found a higher, even when they adjusted KT to volume of distribution, the females in general tend to have a higher KT over V compared to males, which might give us an overestimation of the adequacy. and probably prone males more to PD discontinuation, the use of higher glucose concentration, dextrose, and probably affecting the integrity of the PD membrane and dialysis discontinuation. So this is like part of the potential reasons why males tend to have more PD discontinuation compared with females. But the real reasons are not well understood. And I really want to highlight that in the 2006 ISPD guidelines, they were focusing on achieving a target solute clearance with the not less than 1.7 weekly KT over V. But in the 2020 ISPD guidelines, the main focus was on achieving a goal-directed dialysis. And the concept was not only focusing on solute removal, but also incorporate the clinical status, the quality of life, volume management into the solute removal. So now, some of the strengths of the study that they use a standardized BD discontinuation definitions, which might improve the reliability and comparability of the results. Then it was like a large national cohort. They included around 10,000 patients from the registry, which provided a strong statistical power. They also identified certain modifiable factors through specific mediation analysis that could guide interventions and personalized BD care, hence probably reducing BD discontinuation, hopefully. And though they have, again, a few limitations, which is the fact that the study is an observational design, limit the ability to infer causality. And given the fact the limitation of the registry data, there were some confounder that they couldn't measure, like frailty, hospitalization, socioeconomic barriers, access to healthcare, glycemic control, and others. Then the accuracy of the reported outcome is not independently verified in the registry, which might lead to misclassification bias. They use the term sex and gender interchangeably in the registry, and this is mainly prior to 2018, which potentially might obscure the biological and sociocultural effects. And finally, the study's findings are likely applicable to high-income countries with the comparable access to dialysis and similar experiences with PD management. But I'm not sure with the low-income countries and different baseline characteristic, probably this might affect the generalizability of the reported outcomes and the result of this article. So in conclusion, males had a higher risk of all-cause and inadequate dialysis-related PD discontinuation compared with females. The associations of all-cause discontinuation was partly mediated by comorbidities, while the inadequate dialysis-related effect was largely direct. Identifying these mediators, such as cardiovascular, diabetes, and smoking, provide opportunities to target them and potentially improve PD outcomes. And findings highlight the complex interaction between sex and BD outcomes and the importance of sex-equitable research, recruitment, and care access. So that's it. Thank you so much. And if there's any question or comment.
That was an absolutely great job. It was a complex paper with a lot of convoluted methods, and you did a great job of walking us through all of them. So I guess my first comment is just good work. I guess I'll start by seeing what others in the group think.
That was excellent, Amit. I have a quick question for anybody who's part of the statistics mafia, because I am not. So my question is, and obviously I'm having a hard time statistically wrapping my head around what a mediation analysis really means. And I guess my question is, if you had unmeasured confounders that weren't included in the model, say there was something else that drove the relationship, couldn't the mediation analysis just be a marker for something else that we have not accounted for that now we're dumping on sex? If you understand what I'm saying. And again, I don't have the statistical background to know if that's true or not.
So take this with a grain of salt because mediation analysis is not one of the things that I would consider myself to have expertise in at all. And
Yeah.
maybe before I go and embarrass myself, does anyone in the audience have a strong answer to that question? Uh, I'm not seeing anyone. So my understanding would be any like missing confounders would fall under indirect effects. You still could have like a negative missing confounder. I think one of the slides you showed us showed like for cardiovascular disease, or for one of them, smoking was like a negative 70%. So you can have more than a total of 100% of mediation as you have protective and harmful factors. So you could argue that within those indirect effects, that it will add up to more than 100,
Yeah.
including those missing confounders, but the direct effects
Yeah.
should be more
Yeah.
interpretable.
And then the other question about mediation analysis, again, for the statistics mafia, is if we're missing effect modification, will that impact our conclusions from a mediation analysis? And I'll give you an example here. Say the effect modifier is age. The premenopausal men and women have vast differences in outcomes, but postmenopausal women compared to men of equal age, outcomes are an equalizer. They didn't look, I don't know that they looked at effect modification in specific subgroups. Can that also screw up your interpretation of a mediation analysis?
I'm going to say my guess is yes, but as we are the recorded group, I do not want to put something out there forever that people will then read and misinterpret the mediation analysis.
Right.
So really good questions. My guess is yes, that is absolutely right,
So,
but I do not want that to become part of perpetuity.
so I will take. I was going to take these two back to our statistical editor for our journal, and see those two questions. And if anybody wants an answer, just shoot me an email. I'll include you guys in the answer.
Definitely include me because I would love to hear what he says. Tom, you've got some thoughts or questions?
Yes, thank you. First of all, I share the opinions. Ahmad, that was a fantastic presentation. I mean, world class. I want to give you guys some history and then I'm going to ask my questions. In the late 70s, in Texas, Missouri, and in Toronto, we started using bags, and PD came back from its early iterations. And then from then on until the mid 80s, it really expanded. It grew quite a bit. Around then, I had access to the EDTA data, and that was the only registry really in existence then. And one of the questions that they posed was, why did you choose PD? Now, I want to explain that PD was a new expanding therapy at the time, but and then they followed outcomes for about 3 years. And two of the four questions or options was PD was imposed or PD was first choice. And then they looked at technique survival. And surprisingly, most of us would have thought that if PD was your first choice, the technique survival would be the greatest of all the options that were offered. But in fact, it was imposed. And imposed was never clearly defined. It was judged at the clinics, at the 1,000 of clinics that EDTA looked at. But nonetheless, we have to look at when people kind of didn't have a lot of choice, when their choices were PD or perhaps nothing, that they chose PD or PD was imposed on them. And they had no choice, and that technique survival was greatest. And that's important because that study will never be repeated. And it's kind of an important observation for people to be aware of that when patients have no choice, they tend to hang on longer. Okay. All right. So that's point one. Point two, and this paper corroborates it, and it's important that we all, the data are consistent. 10% of people that go on dialysis withdraw. And that our Navigator program hardly ever mentions that to patients. But patients, we should not be embarrassed by that. That, in fact, should be something that we share with patients and we're proud of. Now, with those observations, I'm going to lead to my question. how do these data, these from this paper, help me in a tangible way? How do they help me? I believe in what Jeff and others have promoted, individualized care. I share the concern over how you define V. And I believe that KT over V shouldn't be the be all and the end all of dialysis. So, and I would imagine everybody that's listening to this would agree with those statements. Therefore, how does the data from this paper help me?
So I would say, thank you so much. I would say the main thing that this paper give us is that we can target certain factors that I'm not sure, but probably can help us with keeping patients on BD more. I'm not sure how much we're focusing on cardiovascular disease and diabetes as a nephrologist, but we really should like tightly control certain mediators that might affect the PD discontinuation. Now, the KT over V, we really, so like here in St. Mike, we don't really depend on KT over V. We depends mainly on clinical outcomes, like clinical symptoms and the symptoms and sign. But probably the main aim of this article were to identify those mediators that can be targeted so we can came with an intervention that can help promoting BD more.
Agreed. Osama, your thoughts?
Yeah, I think to answer Tom's question, I mean, I do agree with like along the lines of that Ahmed took about, you know, if we look at that category right under sex, right, that cardiovascular disease, smoking, diabetes. Now, I'm not going to tell my patients to like, you know, fatten up, right? So the BMI, I'm just going to like leave on the side. But the thing is, you know, when was the last time we had a discussion with our patients about smoking cessation, right? I mean, I haven't had one in a long time, especially with my dialysis patients per se. Now, they may be smoking, right? But like, you know, I just don't smell, right, the tobacco smoke when they come and see me, right, in the clinic. And then, I mean, who even knows what's going on today with vaping, right? And its effect on, you know, kidney function going, you know, down the line and that explosion in vaping. And the other thing too is like, you know, diabetes. There have been countless instances where, you know, I've heard nephrologists just say, you know, I put in a referral to endocrinology, wash my hands, right? That appointment is in 4 months, 5 months, right? That, you know, that they'll be able to come in and see the patient. And at the end of the day, you know, those patients are still continuing to have uncontrolled diabetes, but, you know, in the minds of, you know, a lot of nephrologists, they just check that box of like, you know, or like go see your PCP, right? Like they'll take care of it. But I think, you know, at some point we need to take some ownership of some of these, you know, comorbidities that the patients have, given the fact that we tend to see them more frequently than anybody else, right? Even if they're coming to the dialysis unit for their home dialysis once a month. I mean, even look at all of our in-center patients, right? I see them 4 times a month, right? So, I mean, I think that there's a burden on us that we should help carry to help our patients to get to, you know, where we want them to be, which is, you know, staying on their modality of choice.
Great thoughts. Joel, I think you were next, and then Roberto, and then Jeff.
Yeah, thank you very much. Absolutely fantastic presentation with a very challenging article. I'd like to pick up a little bit on your K2 over V comment, which is really spot on, and that has to do with V normalizing KT. As an example, if you look at the HEMO trial done in hemodialysis patients that included men and women and increased the dialysis dose, and as a whole showed no difference in outcomes. But if you look at the women separately from the men, the women actually had better outcomes at the higher dose. In a study done, I think it was still Gertis, but it could have been Depner. I always confuse the two, and I apologize for that. He actually normalized for body surface area. And when he normalized for body surface area now, the women started the study with a lower dialysis dose, okay? And with the increased dose, they did better. So it's possible that those women were under dialyzed at the beginning using V, as you point out, as using V to normalize as opposed to body surface area. And I think that I hate K2V. Everyone knows it, and because of all these factors. And to say that the dialysis dose, blah blah blah, if they're using K2V, is a real weak point. So I just wanted to bring that to your attention. And then I also want to endorse Dr. Goper's remarks and pick up a little bit on what Osama said, and that is, do we need this study to tell us we have to take better care of the health of our patients, right? We need to tell them to stop smoking, right? I mean, we need to tell them to take better care of this and better care of that. And it would have been, and even if they would have found a factor that really differentiated the cause of mortality on the observational study, I don't know if I can take that to the bank, right? But what I do know is that sex itself is not a modifiable risk factor, you know. So, the utility of the study, I think, is kind of difficult for me to define. But there's a great presentation, so thank you for that.
Thank you.
I just want to make one quick comment, and I'll go to you, Roberto, which is, I think this is also a very selected group. We are all immediately not huge fans of KT over V urea, and I think a lot of us are moving right past that point. And it's an important point, because I think if you were to look nationwide, you may not find the same group that are all going to immediately summarily just put aside the K2 over V urea. So it may be for some in this group that the importance of this study is to support your current actions, but there's a broader audience to this study that hopefully will look at that inadequate dialysis and start to understand the limitations of a single solutes, single metric in defining what is, quote, adequate. And off my soapbox now, Roberto, I'll let you share your thoughts.
Yeah, that's a nice segue, Ankur, because I was thinking about the, unmeasured things here. And one thing that we're missing, of course, is patient-reported information. And I was wondering how, the way that the different ways that men and women cope with symptoms might interfere in what we're seeing here. In some of our studies, we have seen that the symptom burden is perceived in a very different way in males and females, with males, with females being more, resistant, at least to report, compared to men. And if that behavior might have, interfered here, it might be an information that we're missing, and perhaps a motivation for us to include patient-reported outcomes in our, registries, cohort studies, to integrate that information that might change the way we're interpreting the data here.
Agreed. I think that this really calls for, this moved us from what to a little bit of how. I think this brought us a little bit of a mechanism, but it doesn't bring us the why. And I think, to me, the next thing this really calls for is qualitative studies that will explore this further to get to exactly what you're talking about, the individual perspectives that are leading up to that how. Jeff, you've got thoughts?
I want to echo what people have said. When Ahmed told me that this was going to be the article he was presenting about sex and outcomes, I can't say that I was jumping for joy that this is going to be like, super exciting, and we were, but I think, Ahmed, you really did make the very interesting, and I enjoyed every minute of it. One thing I wanted to say that, we know internationally is that there's certain barriers to the use of PD or not in certain countries. So we also have to take it with a grain of salt that this was done in Australia and New Zealand. And we know that in other countries, the mortality of sex on that modality is going to be determined by the willingness to offer the modality equally among both sexes. So I think within each country, and again, that's why I think the PDOPS analysis was very useful that you showed, within each country, there's probably a sex distribution and modality that's somewhat different. And things like assisted PD might offer, more home dialysis to older women who tend to be widowed early, compared to other countries, for example, where if assisted PD is not offered and you're a female widow starting dialysis in your 70s or 80s, you might be shunted to in-center. So it'd be interesting to see as this gets replicated in other countries, if the patterns are the same, and if they're not, it might relate to the distribution of modality. The other thing that we try to look at in PDOPS, and again, to mention about qualitative studies, is we've all had this patient who comes to clinic and the wife knows absolutely everything, all the medications, tells you exactly what's going on, and pretty much is keeping the husband alive, right? And we all know that if that wife weren't there, that husband would not be doing as well as they do. So I think that when we think about sex and outcomes, at least from a socio-cultural construct, I think relationships and caregivers really play a big role into a missing link of understanding the relationship beyond just the biology of sex. So it's an interesting thing. And I guess what I take home is that if sex explains a lot of the differences in outcomes, then it stands to reason that we need to develop sex-specific strategies and interventions and think about treatments equally in sex and in males and females, and make sure that we have equal representation in clinical trials in men and women when we do studies in PD, so we can see if the effects are similar. And I think we ought to not ignore sex, but embrace it in terms of representation in the research that we do. So that's sort of, I think, sort of a broader take home that I have.
Love all of those thoughts and couldn't agree more. Carolyn, you've got thoughts?
Yeah, I strongly agree with everything Jeff just said, and I will avoid repeating every single thing because that was part of my comment. I will say I've done some interviews with both patients and caregivers, and we're still analyzing those data. Of course, patients who do have supportive family report that it was a huge help, really got them through PD. But then some of the caregivers have described the burnout, described the difficulty, sometimes a difficult relationship with the patient because of the complexity of being their caregiver and partner for something that is so heavily managed at home, particularly if it's a patient who without the care partner would entirely not be able to do dialysis. So then they're extremely reliant on that relationship. So I think I'd be curious with an analysis like this or future studies, not just the sex differences, but whether the individual was independent or dependent on a caregiver, roles of other family members. So that's just one comment. And then the other thing I was just to tack on to what was said earlier about mediation analysis, I don't have an answer there, but I will say I'm seeing more and more studies coming out about doing mediation analysis. So we'll need to figure it out sooner or later because it does seem to be the new popular statistical approach to things. Otherwise, this was a great presentation. So good work.
Carolyn, maybe you'll mediate our understanding of mediation.
I'll work on it.
Love it.
I want to learn it. I probably need a statistical guide.
It's like the fancy competing risks du jour.
Exactly. Yes, it does seem to be the newest thing. So it would be good for
Yeah.
us to understand, but I'm not there yet.
Maybe we will try to plan a ISPD journals method club or journal club method series in the future. And you are totally getting voluntold.
Yes, I'm just throwing a study out there for someone to think. What about female physicians caring for PD patients versus male physicians? That would be another spin on sex and outcomes that I think would have interesting results. And there is a literature on this in other areas.
Oh, Jeff, please don't encourage this.
We will be shamed, Osama.
I know. I don't want the shame.
No, Jeff has a good point. And Jeff, it's I think men sometimes have difficulty discussing various things with women. I'll give you an example of one I've got to face soon. Is a young woman from a different culture than Vermont, who is getting ready to do PD, and she she just had a baby, so she's still sexually active. So, a discussion of sexual activity with a PD catheter, I would imagine that it's possible my nurses, my female nurses might be better than me. Let's flip that around. I guarantee you I can talk to men about the use of phosphodiesterase inhibitors in erectile dysfunction better than most urologists, let alone other nephrologists. So Jeff's point's a good one. Is how do you sex-specific recommendations and sex-specific knowledge that we nephrologists have for our PD patients?
Absolutely. But I also think it highlights an area for opportunity. I think that going back to some of the topics earlier on individualizing patient care and personalizing patient care, individualizing physician-patient relationships, I think of it's a little bit, and this I think is partially based off of our own systems in the US. You get the doctor you're assigned to, and oftentimes you're stuck with that doctor, and that doesn't necessarily mean that that is the right doctor for you, whether it is a difference in gender, a difference in culture, a difference in life understanding. I think that understanding that patient physician patient relationship is a really critical one, and probably most so in dialysis where there is so much contact and so much dependency. So it's an area that I think we don't think about enough because we already are all so spread so thin. The idea of maybe I'm not the best doctor for this patient is not the easiest one to execute. Not to mention the US bundling issues and trying to get someone to another doctor and having to have somebody not get paid that month. Carolyn helped me through that recently.
All right, and I think in the interest of time, we have 1 more minute left. So I just wanted to thank Ahmed for a great presentation. I wanted to thank everybody for their contributions to the discussions. It's been phenomenal. And shout out to next month's Journal Club series across the different time zones. So next month we'll be talking about outcomes on peritoneal dialysis in patients with primary kidney disease related to multiple myeloma. So interesting topic, data from the French language peritoneal dialysis registry. So, we were in Australia today. We're going to France next month. So we'll see you all there.
Thank you, guys.
Thank
Take
you.
care, everybody.
Take care, everyone.